So I'm Michelle. I'm a PT, and happy PT month to all my colleagues out there. And I'm here to talk about the implications of shoulder rehab. So what Dr. Stanwood does has a lot of implication on what we do after. So a little bit about me. I started at the University of Maine. I got a bachelor's in biology with a concentration in athletic training and kinesiology. I played softball at UMaine and became yet another ball player with a bad shoulder. So that's kind of where my fascination with the shoulder started. Then I went to BU once I figured out what I wanted to do. I went to BU twice and got my master's in PT, and then went back about a decade later, which pains me to say. But I got my doctorate in PT, and then I taught in the program for 3 years after I got my doctorate. If I'm not in the clinic, you'll find me in the woods. I'm a scoutmaster and a very proud mom of 2 Eagle Scouts. So, but enough about me. We're going to talk about you guys, what I hope you learned from this. Oh, geez. Okay. I want you to understand the basic principles of shoulder rehab, and the importance of the scapulothoracic joint. Most people don't think of it as a joint, but hopefully once I'm done, you'll understand how very important it is. And understand the general rehab principles, when you start range of motion, when you start strengthening, and how does that basic principle change based on what the surgeon does in the OR. And just the overall goal, I just want you to be able to understand the shoulder complex, how it moves, and how surgery is going to change how that moves, ultimately to get a best outcome for your patients. And Dr. Stanwood said it, a lot of people say it, shoulders are complicated. Yes, they are, but I would challenge you to say they're complicated, that's what makes them awesome. It's hard to figure out shoulders, but once you do, they're like the coolest thing out there. So if you don't believe me, just wait. In about 15 minutes, you'll believe me. So knowing the anatomy is the key. So the shoulder girdle is actually 4 joints. We call it the shoulder joint, but we're actually talking about 4 things. The scapulothoracic joint, glenohumeral, acromioclavicular, if you can say that 3 times fast, you win, and sternoclavicular. And dysfunction in any 4 of those is going to lead to a referral for shoulder pain. And how many outpatient therapists have got that script that says shoulder pain, eval, and treat, right? You got to figure out where's the problem, what's going on. So anatomy dictates function, and with the shoulder, there's a lot of anatomy that's going on. But the main things you want to think about is your scapular stabilizers, your rotator cuff, and I really look at the biceps and triceps too, because they do, the long heads do cross the glenohumeral joint. So they're also very important in the rehab of shoulder. But the main thing I want you to, if you remember nothing else from this, understand that scapular thoracic stability is going to give you a good foundation for your shoulder, because that's how your arm is attached to your body, is scapulothoracic stability. So, if that little house in the mountains didn't have a good foundation, it wouldn't be there. If you don't have good scapulothoracic stability, you're going to have nothing but problems at your glenohumeral joint. And then you're going to have problems at your elbow, and it just goes downhill from there. So, take home message, happy scapulothoracic joint equals a happy glenohumeral joint. You can't have a happy glenohumeral joint without a good scapulothoracic joint. So your rotator cuff, I think that's it's just a cool picture. Most people know of it. Not a whole lot of people know a lot about it. I can't tell you how many patients have come to me and said, oh yeah, doc told me my rotor cuff is messed up. It's important. I need to fix it. And they're absolutely correct. But they don't understand why it needs to be fixed and what it really is. And so on your picture here, you're going to see the anterior view and the posterior view. Anterior view is a little weird because there's no rib cage in front of it, but that's mainly your subscapularis. And then on the posterior view, you have the other 3, supraspinatus, infraspinatus, and your teres minor. 3 on the back, 1 essentially in the front, even though it doesn't feel like it's in the front. So what's the functional importance of the rotator cuff? I like to think of things about in functional ways. So, you got your guy there with the crane, and if anybody's ever watched a crane moving things, it's really kind of mesmerizing and fascinating. But the crane, big, powerful thing that lifts things and moves things. And there's that little guy with what's called a tagline. And the tagline keeps things from flying out of control. It keeps everything lined up, keeps the motion where you want it, okay? So if you think about your rotator cuff in that kind of a structure, it makes a lot more sense. As Dr. Stanwood said, the whole thing, you got a really big ball and a really tiny socket. And it's inherently not made for stability. It's made for mobility. It's why you can do all the things you can do with your shoulder. But the rotator cuff grabs onto that humeral head and it pulls it in to hold it into that tiny little saucer that is the glenoid. So all four of them work together to do that, but individually they cover all the other motions that are needed, which is like really super cool to me. The supraspinatus comes over the top, and when it pulls, it gives you that spin, all right? The infraspinatus is weird because it comes from behind, but it comes into the front. So when everything else is pulling, that infraspinatus keeps everything kind of forward in your shoulder. It keeps everything from pulling back. When your lats pull, your shoulder doesn't go way back because your infraspinatus is there to hold it. Your teres minor is in the back. It's going to come in the back of your arm. It's going to keep everything back a little bit to help the subscapularis do that, but it's also going to pull down. So it's going to give you the down while the supraspinatus gives you the spin. So the motion's so complex, but you got just four muscles that are giving you that spin and keeping you from moving forward and backwards, so that the big crane of the shoulder, the deltoids, the pecs, the lats, they can get the arm moving. This is just your tagline holding everything where it should be. And the long head of the biceps and triceps, they cross the glenohumeral joint. They're going to help stabilize, so I always throw those into my shoulder rehab. There's only one exception, but we'll get to that in a minute. So when we're talking about shoulder rehab, we're talking about two things. We're talking about gain and range. We're talking about gain and strength. You always want to get range first before strength. After injury or surgery, it's always the first thing I look at. I always want to get more range of motion. I want to avoid adhesive capsulitis. It's something I don't want to deal with. I don't want my patients to have to deal with. The problem with it is you never know who's going to get it or why they're going to get it. It's very unpredictable. So I just focus on range, get them moving so that you won't have to deal with that down the road. In a post-op position, it's going to allow you time for tendon and tissue healing. So I tell all my patients when I first see them, this is going to be wicked boring, but that's what you need. So just be patient, stick with me. It'll get more exciting later, but you got to do the fundamentals with me with the range. We'll get to the fun stuff later, which is the strengthening. And strengthening, you start with active assistive, you start with cane exercises, then you get into the very exciting day when they can lift their arm up. That's like the coolest day for every patient. They're like, oh my God, I lifted my arm up and I touched the counter. It's great. That's awesome. Your aim gets really low when you're like this for, a month. And always begin with your scapular stabilizer strengthening before you get to your rotator cuff. You got to get that good foundation. So make sure you start there. I will say, and I say it to patients all the time, strengthening is a lifelong pursuit. The SAID principle is the basis of exercise science. It stands for specific adaptations to implied demands. So if you ask more of your muscle than it can give, it gets stronger. If you ask less of your muscle than it's capable of, it gets weaker. It's just that simple. There's really nothing more mystical about it. But that's going to change in your life as your priorities change, right? When I was in college playing ball, I worked out 5 hours a day. I was in great shape. I got married, I had kids. That went away because my family was my priority. Now my kids are getting older. I've already started working out more. I'm getting stronger. It's not a time sensitive thing like range of motion is. The longer you let a joint get stiff, the harder it is going to be to stretch it out. So strength is a whole lot easier to gain than range of motion. So up to the surgeries here. So total shoulders have been around for about 70 years. And there was a systematic review done in 2019 that showed there was no consensus that could be documented between surgeons and surgical procedures on total shoulders. I highlight that because it is very, very important to communicate with the surgeon who sent you that patient, who did that surgery. They have their own ideas of how they want to do it, whether more aggressive or more conservative. So get the specific protocol from that doctor. It's unique in rehab because, it's total knees are kind of, there's a set way that most people agree about. But with shoulder surgeries, you really, really have to talk to the surgeon who did it, because everybody does it a little bit different. And that's how you're going to maximize the rehab for your patient. So all the rest of the presentation is going to be based on Dr. Stanwood's protocols, because he's the shoulder guy at Plymouth Bay. So, and this is really more to illustrate to you guys the delays. So we're starting with the minor surgery, going up to the big daddy at the end there. So subacromial decompression, it doesn't involve a tendinous repair, so you don't have to worry about letting things heal. You can really get after it right away. So active assistive range of motion, you could start that at 3 days. They could start lifting their arm at 2 weeks, and you just get after it. Resistive thorax, you put a weight in their hand, you can start doing that at 6 weeks. Those people are usually pretty happy. They plug along, everything's great. Again, start with scapular stabilizers before rotator cuff strengthening. Rotator cuff repair, so this gets a little trickier because there's a bunch of curveballs you can get in the middle of it. It's usually a supraspinatus tendon repair, not always. And it can also involve the long head of the biceps. If it does, then your active range of motion, active assistive is gonna be delayed. Dr. Stanwood usually does what's called a biceps tenodesis. Basically, he just takes the long head of the biceps off the labrum and sticks it onto the humerus. So it no longer crosses the shoulder joint. So you don't worry about when you're doing your range of motion, no worries, because it's not there anymore to have to stretch. But the problem becomes it also works on your elbow, so you can't bend your elbow. And if you've ever told somebody you can't bend your elbow for 6 weeks, they get very unhappy with you very quickly. So you just keep after them and say, you know what, put the time in now, it'll get better, you'll be happy for it. So again, you can't do any active elbow flexion until 6 weeks post-op. And then you start from there. Your active range of motion, active assistive range of motion, if it's a small or medium tear, you're not really that delayed from a subacromial decompression. It's only 1 to 2 days. But if it's a large tear now, you can't do active assistive range of motion for 6 weeks. So you can't lift that arm up for 6 weeks, which is really a bummer, especially if it's your dominant arm, right? And then active range of motion, 5 weeks if it's a small, medium tear, 8 weeks for a large tear. So just in that, there's a big difference of when you can move your arm. And you don't put a weight in their hand till 10 or 12 weeks, which is, you can't lift anything. And even, before that, they say, oh, you get out of the sling, you can lift a coffee cup. And everybody goes, oh, coffee cup? Yeah, that's it, because you got to let the tissue heal. Total shoulder replacement. This is kind of where it gets more complicated. So the surgical technique in this, they dislocate your shoulder, and it's an abduction, external rotation position, right? So you can't do that for 12 weeks. So there's a lot of personal hygiene things you can't do that are really problematic. Anybody got any ideas of what would be a bummer with this? Washing your hair. What else? Yep. Can't do anything armpit related, which is really a bummer. What else? Anybody? Brushing your teeth. People, they say they brush their teeth like this and they, get toothpaste all over themselves and they get really bummed out. And I say, don't worry about it. It will get better. Just, you got to put up with the toothpaste on your face a little bit longer, but trust me, have faith. This will be good. And really in early rehab for these people, it's really just about reassuring them that you can't do anything now and it's really a bummer, but it will get better. Just stay the course, stay on the protocol, because it just takes one quick movement to have a rupture, have a tear, and bring yourself right back to the beginning again. So deodorant, shaving under your arms, washing your hair, getting a shirt on, these are all things you can't do anymore. And you can't do them for, 6 to 8 weeks, so you're thinking you can't shave your armpit for 2 months. You can't really brush your teeth well for 2 months. That doesn't fly well with a lot of people. So there's a lot of encouragement, a lot of pep talking that goes on with rehabbing somebody with a total shoulder. So this was when Dr. Stan was talking about the subscapularis repair. So that's the one that comes from underneath your armpit, comes up front here, right? So he pulls that off, replaces it, and then he sticks it back on there, right? So what we don't want to do is external rotation, because that's going to stretch that subscapularis out, And you don't want to tear that because then you're right back into the beginning, and nobody's happy with you if you do that as a therapist. So there's going to be restrictions of no external rotation past 30 degrees because you got to let that tendon repair before you start yanking on it. And you're going to have that for about 6 weeks. But passive range of motion can start at 2 weeks with the restrictions. So you don't want to pull off that subscapularis. So external rotation to 30 degrees, forward flexion is going to be about 130 because if you go all the way up here, that rope between here and here is going to get too tight and it's going to pop. And again, nobody will be happy with you if you do that. Active, they can't lift their arm for 6 weeks. So they're going to be in that sling for 6 weeks. So they're going to get very frustrated. They're going to be tempted to ditch the sling. Just keep talking to them. It'll be good. It'll be worth it. And don't ditch the sling at 5 weeks after you put, almost a month and a half in and now you're back to the beginning because you did something not thinking about it. That's what I tell them. It would really be a bummer that you've come this far and now you're back at the beginning again. You can't get a weight in your hand for 12 weeks, which is what everybody wants to do, right? Everybody wants to get back moving. They want to be able to cook. They want to be able to clean and do things and feel productive again. You can't really do that for 12 weeks. So 3 months of not using your arm, and if it's your right hand and if it's your right arm and you're right-handed, think about not using your right hand for 3 months, right? It just seems insurmountable. But you just tell them it'll be worth it. It'll be worth it. It'll be worth it. So reverse ball and socket is, to me, like the coolest thing ever because, you get your regular shoulder that is very complicated, relies on the rotator cuff, and then they just switch it. So now you don't need a rotator cuff. And that mechanically to me is amazing that you can even do something like that. So that dislocates your shoulder with your arm adducted, internal rotated, and extended, right? So for polite company, we call that the shirt tuck position. I'm sure you guys can think of other ways to describe that as to something that you shouldn't do. But there's also functional implications to this. So what would you not be able to do? What would you not want your patients to do? I don't know, everybody shout it out at once. What? Tuck your shirt, put your belt on, get your belt through belt loops. Guys have a big problem with that. For the women, bras and shoulder replacements are like mortal enemies. They don't go together at all because you can't latch your bra behind your back. And washing your back, tucking in your shirt. You can't do those things, right? So you ask a guy who's been wearing a belt for his entire life for 60 plus years and say, you got to take your belt and slide it through your pant loops, then put your pants on. You might as well tell him, go climb Mount Everest because you've been doing it on while the pants are on forever, right? So it's very disruptive, but just keep telling your patients it's disruptive. It's going to be, frustrating, but it'll get better. You'll be able to move your arm better. The only caveat is with a reverse ball and socket, they're not going to get full range of motion. They don't, in my experience, they don't really care because they've been doing this for so long that they can now do this and life is grand, right? So the expectation from Dr. Stanwood's protocols are about 130 degrees of flexion, about 30 degrees of external rotation. But if you're somebody who you've been doing this to get something next to you and now you can do this, like the world's your oyster. They think this is the best thing ever. So as long as they stay on the protocol, I just say, you know what, these are the rules, these are the laws, we got to obey them, everything will be great. So for this, active assisted range of motion is not for 4 to 6 weeks and it's only in the clinic. So we'll get clearance from Dr. Stanwood to do it in the clinic with them, very supervised, very carefully, because we don't want them to pull that subscapularis out and we don't want them to do any further injury. But they can't lift their arm for 6 weeks. So again, you tell somebody you're not going to be able to lift your arm for a month and a half. It's a big challenge for most people. And you can't put a weight in their hand for 3 months. 12 weeks, you can't put a weight in your hand. So it takes a lot of patience, and that's what I spend most of my time with, people saying, is just be patient. It's boring, it's gonna take a while, but it's gonna be worth it in the end as long as we do it right. So, just in general, as the level of rotator cuff or glenohumeral disruption increases, whether surgically or through injury, just keep in mind that the restrictions on that rehab are gonna increase, and all your timelines of recovery are gonna be delayed. So the more disrupted your rotator cuff becomes, your glenohumeral joint, it's going to take longer to get it back. And that is the hardest part of PT for people with shoulder injury. But when it comes together, man, it's pretty awesome for somebody to be able to move their arm again. And just keep in mind, any glenohumeral immobilization, you put somebody in a sling for, 6 weeks, their shoulder blade's going to get weak. And what's the most important thing about shoulder rehab? Shoulder blade strength, right? Scapular stability. So keep that in mind. And then just understand that any of the restrictions that a doctor has, they're not arbitrary. They're based on what they did mechanically in the surgery. So just remember that whatever that surgeon did, that's going to limit what you can do after, and make sure you get the protocol from the surgeon so that you know what you can and can't do. So that's it.